Good evening, everyone, and thank you for joining us for tonight's webinar. My name is Rebecca, and I am the Cancer Management Program Officer at Central and Eastern Sydney PHN. I help manage two new cancer services at CESPA, which have been developed to assist general practices to support their patients with cancer on the view screen. I'd now like to introduce our first presenter for tonight. Dr. Megan Crumbaker is a medical oncologist at St. Vincent's Hospital, Sydney, and the Kinghorn Cancer Centre. And tonight we'll be presenting an update on treatments in advanced prostate cancer.
There we go. So I'm Megan Crumbaker. I'm a medical oncologist at St. Vincent's in Sydney, and it's affiliated Kinghorn Cancer Centre. And I treat primarily prostate, kidney, bladder, urothelial carcinoma, but I'm also part of the GP Can Share program, which Simone will talk to you about in between the talks. And so I'm certainly a port of call if there's anything I can help you with linking into any of the other cancer types as well, both for the localized patients and the metastatic patients if you're stuck. For who to speak to or how to get a referral or whatever question you've got. So the learning outcomes for my talk today, which is on the advances in recent advances in prostate cancer, so updated since last year when I provided a similar talk, but I've made a lot of changes, so hopefully you'll still get something out if you saw my previous talk, is to gain an overview of the recent key changes in the management of prostate cancer. So it's been a really rapidly evolving space. So just to help update on that, understand some of the imaging strategies in prostate cancers and their indications. Certainly around here, you'll see a lot of patients getting PSMA PET scans, but I talked to you about kind of the pros and cons of the different imaging strategies, and also to go through a case study where I identify some of the common side effects from prostate cancer treatments, and I'll just touch on their management. There's not a lot of time in kind of 30-35 minutes, but I'm hoping to leave some time for questions at the end, so we can go through that. Also happy to take questions throughout. If you put it into the chat line, they'll let me know. So overview of the talk, just a quick overview on prostate cancer, and I'm focusing on advanced or metastatic prostate cancer, treatment paradigms in advanced prostate cancer and recent changes, as well as emerging therapies. And then I'll run through a case study that kind of goes over some treatment options in the clinical context, imaging strategies, and also some potential adverse events, and also why your involvement as the patient's general practitioner is just so important in this population. So just really basically, most prostate cancers, particularly in Australia and around Sydney, will be diagnosed as a localized prostate cancer, but there's a really big range. There's about 5 to 25% of new prostate cancer diagnoses will just be metastatic at outset. And prostate-specific antigen, PSA, is really widely used as a tumor marker for the detection and monitoring of prostate cancer. And prostate PSA expression is regulated by the androgen signaling. And so androgen and testosterone, as a result, mainly testosterone, is really important in the growth and pathogenesis of prostate cancer. And therefore, androgen deprivation therapy is still the cornerstone for metastatic prostate cancer management. Despite all the new treatments coming through and the changes, ADT remains a cornerstone of treatment. There's some really important definitions when looking at prostate cancer. There's quite a lot of them, but to keep it succinct, really, first of all, the extent of the disease is very important. Is it localized? Is it regional, or also known as locally advanced, or is it metastatic disease? And so that's nodal disease, distant metastases in the viscera or bone beyond the kind of local pelvic nodes. And within localized disease, we risk stratify the patients using their tumor, their T&M score, so tumor staging nodes, and whether or not they've got distant metastases. Their PSA level is also used for stratifying the risk. The extent of a biopsy involved, so how many cores are involved with cancer, and particularly we look at the Gleason, or now it's generally known as the ISEP grade group score, although it's been updated, we still quote the Gleason score. So that's really for localized disease, which I'm not going to focus on today, but for metastatic disease, there's some really important delineations as well. So for our data with metastatic disease, all the international trials use conventional imaging. And so the staging of metastatic disease is using a CT and a bone scan. And so if we're enrolling patients on any treatments, or we're trying to make treatment recommendations, sometimes even if they've had a PET scan, sometimes we will need to do a CT and a bone scan, even though, I tell the patient we're not going to find anything additional, but it is what our data is based on. But we do a lot of PSMA PET imaging because it is more sensitive. Another really important delineation in metastatic disease is it hormone sensitive, or is it castrate resistant disease? So hormone sensitive means you give that androgen deprivation therapy, whether it be orchidectomy or an LHRH agent, and their cancer responds. But once their PSA starts to go up to a certain level, despite a suppressed testosterone level, that's when they've developed castrate-resistant disease. And that's really important because that's a delineation, the different treatment strategies, the different trials, and what PBS will reimburse is variable depending on if they're hormone sensitive or castrate-resistant. And then now, there are some treatments that are looking at in M0 disease versus M1 disease. And so M0 are patients that basically have no evidence of metastases on conventional imaging, or they might even have just local lymph nodes. And so that's an important disease space now, because there's some treatments being inserted into that space as well. And so particularly in the castrate-resistant setting, M0 has become really important. So it's patients that have had their definitive localized treatment and their PSA has come back up. So they definitely have micrometastatic disease, but it's not being picked up on a conventional scan. So looking at prostate cancer, it can be a really long journey for some patients. So over on the left is where they're getting definitive treatments, and they might be cured. And then as you move across, that's when they've developed either micro or overt metastatic disease. And you can see the PSA waxes and wanes depending on their treatment. And so patients can be on treatment for quite a long time. And essentially from this treatment initiation onwards, they might be on androgen deprivation therapy for the rest of their lives. And that could be 3, 4, 5, 10 years, it could be quite a long time. So managing toxicities and these patients and their holistic care is really important. And so over on the left, when they're at this early phase with localized treatment, the options are surgery, radiotherapy, plus or minus androgen deprivation therapy. And then once they get more systemic disease, so either they relapse after these definitive treatments, or they present with metastatic disease at the outset, then you're looking more at drug therapies. You're looking at androgen deprivation therapies or androgen signaling inhibitors, and those are the first generation ones like bicalutamide, or the more importantly these days, the novel androgen signaling, or the newer generation ones like abiraterone, which is a CYP17 inhibitor, or enzalutamide, darolutamide, or apalutamide, which are newer generation androgen receptor blockers. So similar to bicalutamide, but kind of on steroids essentially. Also in the metastatic setting, we're looking at using chemotherapy, and that's primarily the taxanes like docetaxel and cabazitaxel, which generally are well-tolerated chemotherapy agents, which is really important because this tends to be an elderly population. And then we might use some local treatments depending on if they've got symptoms or the extent of their disease. So that might be some palliative radiotherapy or even surgery, depending on what the issue is, such as if they get ureteric obstruction. And then later on in the disease, we have some other approved therapies like targeted treatments like PARP inhibitors for patients with particularly BRCA mutations and some other DNA damage repair mutations. So just looking at the treatment paradigms, so really the biggest thing is that treatments in general are moving earlier in the disease spectrum. So particularly, I'm talking particularly about metastatic or advanced prostate cancer. So whereas we used to just string treatments together, we'd start with the androgen deprivation therapy, and then we'd wait till they become castrate resistant and have some progression of their PSA or their symptoms or their scans. And then we would add something on top of the androgen deprivation therapy. And now the big changes is that the androgen deprivation therapy, or ADT, is still the foundation. So they go on their LH-RH antagonist or agonist, or they have their orchidectomy. That still goes on, throughout the metastatic disease process. But now we're adding extra stuff on right from the get-go. And so those treatments can be chemotherapy, like docetaxel chemotherapy, or it can be those novel androgen signaling inhibitors that I mentioned, like enzalutamide, apalutamide, or abiraterone. And this is in the hormone sensitive setting. So rather than holding those treatments back like we used to in the until they got castrate resistant, we're using those up front. And additionally, even in the M0 setting, so castrate resistant setting, so these are patients who have had treatment with their androgen deprivation therapy, and then their PSA has gone up despite that. So they're castrate resistant, but you do a CT and a bone scan. It used to be we didn't have a standard treatment to do in that situation, but now using a novel androgen signaling inhibitor has proven to have a benefit in that setting as well. So using either, we have access to enzalutamide or darolutamide in that setting on a compassionate access program. So really, it's turning into more is more. And it's really important in these studies, the comparator arm in these studies was androgen deprivation monotherapy, and then the patients either got, the chemo or the novel androgen signaling inhibitor or all three. And even though patients subsequently got more those treatments later on, they got more benefit from getting it up front rather than using it once they became resistant. So it's really important. I see there's a question about theranostics, and I will get to that a little bit later. I'll touch on that because I know that's very topical. This is the foundation that more treatment upfront is resulting in better outcomes. So longer survival by, a year, 2 years in some instances. So significant, we're not looking at a few weeks extra for these men. And that's despite them getting these same treatments later on in their disease course, but using them early is really improving outcomes. But access is a major limiting factor. And there's a lot of misinformation with patients where they'll talk to somebody and they'll say, basically what we can access right now, we can get docetaxel on the PBS and we can get ADT in the hormone sensitive setting, but these other drugs, the enza, abiraterone, those are not funded on the PBS until they have castrate resistant prostate cancer. And the benefit is much bigger in the hormone sensitive setting, but we can't access it on PBS. So we have to ask the patients to go on cost sharing programs, and it's quite costly. So some can't afford it. So some have to go on ADT monotherapy. Or if they've got enough volume of disease, we might give them docetaxel. But access is a major issue, and it does confuse the patients because they'll talk to other patients who, will say, oh, I've got abiraterone on the PBS. It's, why aren't you getting it? Why is your doctor not giving it? And it's because that patient would have gotten it in the castrate resistant setting. So access is a major issue, and we are lagging behind in that regard compared to a lot of other countries. So I'm going to move on to a case study to cover some of these points on, more specifically on treatment. So I Googled what a 65-year-old man looks like, and that's what came up. So there he is, I guess, a bit of a silver fox. I don't know if I'd say he looks 65, I'm not so sure. But anyways, we got a 65-year-old gentleman who presents with lower urinary tract symptoms. So he's having a lot of nocturia or difficulty passing urine, and a PSA is done and it's 56, so quite elevated. And a rectal examination identifies what feels to be T3A disease, so a bulky tumor. And so the patient's referred to a urologist, and perhaps it was a urologist that did the DRE for argument's sake. But a biopsy is performed, and that identifies prostate adenocarcinoma, so a prostate cancer. And it's a Gleason 4+4 or a grade group 4 cancer. So it's a high grade cancer. So really when you're talking 8, 9, 10, those are high grade. So it's a significant cancer, looking at one, it's Gleason, and also it's PSA, and also the size of the tumor. So if you were risk stratifying this by some criteria, this would be called a high risk localized prostate cancer. So the question is, and we don't have any fancy polls or whatnot, but essentially The question is he's got a high-grade prostate cancer, he's got a significantly elevated PSA, what imaging would you request at this point? And so I've got a few options. So await, further specialist, oncological specialist opinion, such as a med-onc or a urologist. Request a CT, chest, abdomen, and pelvis. Do a whole body bone scan or an MRI of the pelvis or a PSMA PET CT scan. Just a moment to think about that, think what you would do. And so basically, any of these could be perfectly appropriate. So a lot of times before the biopsy, the urologist would do an MRI to help guide some extra targeted biopsies. So they do tend to take quite a lot of biopsies on a template, but they might target if they feel something specific on the examination or they see something on the MRI. So a lot of times they would have already had an MRI if it's a localized, seemingly localized presentation. Internationally, a CT and a bone scan would be the thing done for this patient to stage to see if they've got systemic metastases. So basically any patients with an intermediate, unfavorable or a high risk prostate cancer, and that's based on, there's a lot of different stratification tools, but that's based on kind of their extent of disease on examination, the biopsy findings, and the PSA. This patient would fall into high risk. They should have some kind of imaging to exclude metastatic disease before they go on to have a surgical or a localized radiotherapy intervention. So this patient does need systemic imaging. But what you'll find in Australia in particular, you'll find that most of these patients will end up having a PSMA PET CT scan. And that's essentially because we've got good access to it and it's very sensitive at excluding metastatic disease. So the surgeon would feel more confident proceeding to, a radical prostatectomy if they don't see any overt metastases on a more sensitive scan. The tricky thing is the PET scans do tend to cost, $600 to $700, whereas I can get CT and bone scan for free for my patients. But generally, this is something that is these patients would still be with a urologist a lot of times at this point. But really, any of these are appropriate with different caveats about them. And so when you think of imaging in prostate cancer, the goals, you're really thinking of what's the goal of the imaging. So in localized disease, you really want to be quite specific about the extent of the disease because you're thinking about doing aggressive localized treatment. So you're doing a prostatectomy or you're thinking of you're thinking about doing really, quite high doses of radiation therapy. Those have toxicities and you're doing them to try to treat the patient. So you want to be really sure that they have a high chance of cure with those localized treatments. So a really sensitive scan like a PSMA PET is very useful. And also they use multiparametric MRI for looking at the pelvis and staging it accurately. And if they've got high risk or intermediate risk disease, you might need to do a CT and a bone scan. By international standards and by what you can get cheaply, oftentimes it should be a MRI and a CT and a bone scan. But what you'll find in practice around Australia is there's a lot of PSMA PET scans being done in this situation. One option is to do the CT and the bone scan. And if there's no metastatic disease on that, then to do the PSMA PET scan after that, because if they've got overt metastatic disease, they don't really need to pay that extra money for that sensitive scan. But around Vinny's, you'll find that a lot of patients just have the PSMA PET, and there are some funding options to try to get some of the more disadvantaged patients those scans for free if they're being considered for a definitive localized treatment. In the metastatic setting, really you're trying to risk stratify the patient. So there's some stratification on low volume, high volume disease, and that's based on number of bone metastases or whether they've got visceral disease, say in the liver or other organs. And so being really specific about the extent of the disease is a lot less necessary when you know they've got metastatic disease, because you just need to kind of risk stratify them. And those risk stratifications were based on CT and bone scan in international trials. So a CT and a bone scan is generally perfectly acceptable in metastatic setting. And the nice thing in prostate cancer is we don't necessarily need to do a lot of re-imaging in prostate cancer, because generally if the patient feels well and their PSA is low, we don't need to keep re-imaging them. The time you re-image is when either their clinical symptoms are progressing and their PSA is low, or their PSA is starting to go up with a certain pace, and then you do need to rescan. But PSA oftentimes is good for monitoring the burden of disease in the early phase. And then you might need to do a PSMA PET if you're thinking about the radioligand, the targeted lutetium PSMA treatment. Or some patients, for whatever reason, the extent of their cancer is underrepresented on a CT and a bone scan. So sometimes they end up having serial PET scans. And you might do an MRI if they've got some evidence of a neurological compromise that you're worried about cord compression. So MRI would be very much symptom directed. So this guy with the 65-year-old guy with the lower urinary tract symptoms and the PSA of 56 with the Gleason 8 prostate carcinoma on PET scan, on biopsy, undergoes a PET scan, and he has really extensive disease. And you can tell it's a PSMA PET scan because the salivary glands are really hot, and you've got a lot of PSMA expression there, and the brain is cold. So on an FDG PET, you're going to see the salivary glands are cold and the brain is really hot because there's a lot of glucose uptake. So this guy has, so you always see a bit of uptake in the liver anyway, but he's got a lot of bone metastases. All these black dots are bone metastases essentially. And then he's got a really extensive prostate primary. And so this guy has a high volume, bone only metastatic prostate cancer. And he just has some lower urinary tract symptoms. So in light of this result, what would be the best treatment for this guy? So we could have ADT alone, ADT plus docetaxel chemotherapy, ADT plus one of the androgen signaling inhibitors, ADT plus one of the androgen signaling inhibitors, abiraterone plus docetaxel, or multiple options above. And so really several of these are options or clinical trial is always my caveat. So in Australia, for this guy, what we could get funded is the ADT plus the docetaxel. He could just have that on PBS. And with that, the study that we saw that in was charted. That was about 2015. And it showed a very significant survival benefit for adding docetaxel to ADT. And that was especially in the high volume patients. And high volume was at least 4 bone metastases and visceral metastases. And the median overall survival went from 34 months to just over 51 months. So, it's not a small improvement in survival. And what was found is that while the patients had chemotherapy, they just get 6 cycles. So it's about 4.5 months. Their quality of life goes down a little bit at that time, but then their quality of life improves back to where the ADT patients only were. And it's better for longer because the ADT only patients, they start to relapse and their quality of life goes down because their cancer is growing. So this does tend to be chemotherapy that's reasonably well tolerated, and it does have a significant benefit. And what I tell my patients is it's not about dropping their PSA in the short term. It's about keeping that PSA down and keeping the cancer under control in the longer term, because ADT will drop a lot of men's PSA very dramatically and very well. And so they say, why do I need chemo? Because, I'm clearly responding, the cancer shrinking, but it's about that more prolonged benefit. And you get a more maximal benefit from using it in this setting rather than waiting for castrate-resistant disease. And there have been trials proving these other options as well, and I'll gloss over that a little bit. But what we can access, unfortunately, in Australia is only the ADT plus docetaxel unless you put them on a cost-sharing program. So just last month, there was a release on triplet therapy. And so patients are going to be looking at this. And so that's this one of the novel androgen signaling inhibitors, abiraterone plus chemo plus ADT, and there was a massive improvement in radiographic progression-free survival, a significant reduction in death, and a 1.5-year improvement in median overall survival with the patients with high volume disease. And so, that's massive, but at this point, you'd have to be asking the patients to go on a cost sharing program for that. So, you know, with this, there's a lot of talks that we have to, difficult talks we have to have with patients about, you know, access. And it's something that they might bring back to you as their general practitioner saying, you know, what should I do? You know, should I be paying these costs for these drugs or not? Or, you know, it's very stressful, and they can use the support of a practitioner that has hopefully a good longstanding relationship with them. And so this is where delineating the extent of the disease I mentioned is really important in kind of choosing some of these escalations of treatment. So you might have a guy with the same symptoms, same PSA, same biopsy result, and you might have nothing on the bone scan. You might just have, you know, one metastases in the pelvis or maybe two in the bone scan, or you might have, you know, dozens of metastases on the bone scan. And what we recommend is different for those different guys. So the guy I mentioned has high volume disease, but you know, in lower volume disease where they only have a handful of metastases in the bones, or, you know, only nodal disease, their outcomes tend to be a lot better. And so, you know, some of these men, we might do observation if their PSA is going quite up slowly and they're otherwise well and they have low volume disease and they're not necessarily, you know, the fittest patient. Or they may have androgen deprivation therapy plus or minus one of those novel androgen signaling inhibitors. Some I will use chemotherapy on, but there'd be in the low volume disease setting, the benefit is a bit less. So I might not recommend chemotherapy in these guys. But certainly there's been a survival benefit shown to irradiating the primary, even in a metastatic disease for low volume. So we might do androgen deprivation therapy plus some radiation to the primary, not thinking we can cure them, but it does improve local control and also survival for the patients. It does have an advantage. And, you know, there's some really small data on zapping the metastases if they only have the few, but that's not by any means standard treatment. So, you know, this patient with the high volume disease, he goes on to androgen deprivation therapy and docetaxel, which is a taxane chemotherapy. So what are some of the possible side effects of this regimen? Could it be neutropenia, dyschezia, so, you know, really bad metallic taste in the mouth, alopecia with hair loss, pneumonitis, or all of the above? So certainly you can get all the above with docetaxel chemotherapy. Alopecia would be in more than 95% of the men. They'd get a lot of hair loss kind of leading into their second cycle of treatment. Dyschezia, very common. The patients complain about it, you know, making their food just taste terrible. And so, you know, you can recommend, they say, not using metallic cutlery and using kind of more marinades and spices to kind of cut through that flavor. But it does resolve after they finish the chemotherapy, but it can really kind of impact on their nutritional status. And neutropenia does occur in a high proportion of patients, but saying that, febrile neutropenia only occurs in about 10% of patients. So the neutropenia tends to happen about 7 to 10 days after the chemotherapy, and it tends to only last for a couple of days and then come back up. So the patient might not even know they have it. But it is obviously, if they have febrile neutropenia, that's a medical emergency, and that's one of the things they have to present to us to assess if they're neutropenic and febrile. We have to admit them. And then pneumonitis is a really rare complication of taxane chemotherapy, but it can be very serious and life-threatening. And so get very wary about a patient on taxane-based chemotherapy who's complaining of increased shortness of breath. 9 times out of 10, it's a little bit of fluid retention and it's okay, and you can manage it. But, you know, well, probably 99 times out of 100 it is. But that rare case of the pneumonitis where they can get breathless, there's no kind of proven treatments for it, and it can be definitely life-threatening. So with these chemo, generally very well tolerated, but the febrile neutropenia with the risk of sepsis and pneumonitis are really the big things to look out for. And so in piece 1, that triplet therapy I mentioned trial where they got either ADT and docetaxel or ADT, docetaxel plus abiraterone. This table is just helpful for kind of understanding what the side effects are and what they're attributed to. So the neutropenia neutropenia comes from the chemo, from the docetaxel, because both arms got that. So about 5 to 10% can get febrile neutropenia, whereas the ones in blue, that's what you get from abiraterone. So that's a drug that you'll be seeing used a lot in prostate cancer, and maybe a bit more, you know, with cost sharing programs and it being shifted earlier on disease. And the main side effect of abiraterone is it can cause like a Conn's syndrome. And so they can get hypertension and hypokalemia and edema. And so with abiraterone, that's a really common side effect. But generally, you know, these treatments are, some of these patients come in and say, you know, I'm 75. Why are you giving me chemo? Why are you doing this? But a lot of my patients make it through, and they make it through doing what they want to do during their treatment. Sure, they know they're on chemotherapy, or, you know, they feel a little bit different, but you know, more often than not, they feel good and they feel okay on that treatment. And they get through it and, you know, have a much better survival benefit. So the patient responds well to these treatments. He completes 6 cycles of docetaxel and then has ongoing ADT thereafter. So what are some important considerations going forward for this patient? So should he have genetic counseling plus or minus germline testing? What about his bone health? What about cardiovascular health? What about mental health? What about sexual health? And I'm sure you can guess the answer to this. All of the above are really important. And that's why, you know, engaging with this patient specialist GP is just so important. So with the genetic counseling, I've got a slide on that, but basically all patients with metastatic prostate cancer on international guidelines are recommended to get germline testing. And that's because it used to be, it was just to detect mutations that might affect their family members. But now it is also because there's treatment strategies you can direct. So if they've got a BRCA mutation, you know, we might give them a PARP inhibitor later on. So it's got ramifications for the patient themselves as well as the family members. With bone health, recommend they need baseline bone mineral density because they will have an accelerated bone loss due to the androgen deprivation therapy. And using these novel androgen signaling inhibitors, we're hitting the testosterone even harder. So their bone health is really critical. And these men, you know, these men are living on average with metastatic disease up front. They're living 3 to 5 years, and some are going beyond that. So, you know, these things are important. They can cause big problems, particularly a pathological fracture that can, you know, compromise their quality of life. Cardiovascular health, you know, ADT causes increased cardiovascular risk. The abiraterone can cause hypertension. So it's very important to look after their cardiovascular risk factors. Mental health, you know, they've got an incurable disease when they've got metastatic prostate cancer, and looking after that, as well as, you know, the effects of androgen deprivation therapy on relationships and, you know, feelings of virility and things like that are really important. And sexual health is also really important. So I always offer my patients, we have a great psychology team at the Cancer Center at St. Vincent. So I always offer them an appointment if they want. Sexual health, I think we fall down a lot on, but we're working on that. We've got a new CNC working on some projects to help with that. And a lot of the ADT companies actually have programs that can look at those side effects and give some counseling. And then with the cardiovascular health, I generally enlist the general practitioners' help on that. But with the genetics and genomics, you know, there was a consensus conference of a lot of international experts that looked at it, and really, you know, in the localized setting and family history, there's a little bit of disagreement, but in the metastatic setting, there's a lot of agreement that germline testing should be done. And it's regardless of family history, because what a lot of papers have found that regardless of a family history or not, about 10 to 17% of men with metastatic prostate cancer can have a pathogenic mutation. And like I said, that can be important for therapeutic decisions, and it can also be important for prognosis and also family member kind of upfront testing. And so it's particularly the BRCA1, 2, and then mismatch repair genes that they recommend. Again, access is a problem because it's not funded by the PBS, but at St. Vincent's, we've been really lucky to have a really strong genetics team. And we also have some trials that sometimes can get them free germline and somatic testing. So our patients tend to be really well looked after in that regard, but it's still a deficit at a lot of centers in Australia because of it not being on the MBS. And this article I actually find really helpful for making some really specific recommendations on cardiovascular health, bone health, managing some of the side effects of ADT, like, cognitive decline, memory problems, gynecomastia, hot flushes. There's a lot of really practical solutions. And so, you can't read all this, but this article is really helpful in kind of outlining, and they've got a table with a really good breakdown of their recommendations. So I find it, there's lots of sources for this information, but it was a really good comprehensive review that I think would be really relevant to general practitioners looking after some of these patients with prostate cancer. So going back to the case study, this man progresses, his PSA begins to rise really rapidly after 2 years of being on the abiraterone and prednisone in combination with he went on to docetaxel. So then with castrate-resistant disease, he goes on abiraterone and prednisolone. So with abiraterone, to prevent that Cons-like syndrome, you always prescribe it with prednisolone. So they always go on a 5 milligram dose. So they have that in combination. So a patient on abiraterone will always have some prednisone prescribed, or occasionally they'll get switched over to dexamethasone, but it's actually part of the PBS requirement, and all the trials were the same. And that's to prevent some of the toxicity that you get with abiraterone. So with the abiraterone, what are some potential side effects? Hypertension, increased bruising, hypokalemia, peripheral edema, or obstructive LFTs. And actually A through D are all possibilities. So hypertension in about 5 to 10% of men. And that's ideally managed with an ACE inhibitor or an ARB. That's usually our first line treatment, but it's managed as per essential hypertension, but with a favoring of an ACE or an ARB being your first line treatment. But there's no, special targeted drug for treating it. It's a general kind of practice guidelines for even essential hypertension. Increased bruising you'd get from the prednisolone. Hypokalemia you get from the abiraterone. Peripheral edema is like that Cons syndrome that you get from the mechanism of abiraterone. Basically, you get some mineralocorticoid effects by the way the CYP17 inhibition shunts kind of down the steroid pathway to reduce the testosterone level. But you wouldn't get obstructive LFTs. You can get very rarely, about 1 in 1,000, get some a transaminitis with abiraterone. So this patient remains on abiraterone for 2 years and then progresses. Other options in Australia would include, you could give him docetaxel again, depending on how he went. You could give another taxane chemotherapy, cabazitaxel. You could give enzalutamide, which is another androgen signaling inhibitor. The side effects tend to be pretty minimal with that, but some cognitive impairment and fatigue happens in a small set of men that can be quite dramatic. So that's another hormone manipulating drug, but just because it's a tablet that's not chemo doesn't mean it doesn't have side effects. And PARP inhibitors are accessible on an access program. So we can get PARP inhibitors, not on PBS yet, but we can get some access for that. But some emerging strategies, just to touch really quickly. So we have some genomically driven treatments coming through. So PARP inhibitors for the patients with the BRCA mutations or the DNA repair mutations. We're also seeing PI3 kinase and AKT inhibitors coming through. So that's more the precision medicine model. But in prostate, what we're finding is you can't use just one drug. So they still need to be on ADT, and these targeted drugs probably need to be used in other combinations. And then as per the question in the chat line, so PSMA targeted treatments, so imaging and therapeutics is really, really emerging. So the nice thing about PSMA directed treatment, so prostate specific membrane antigen is a receptor that's overexpressed on prostate cancer cells preferentially, and also the salivary glands, as I showed you in the PET scan. And basically, with the PET scan, what they do is they have a ligand that binds to the receptor, and they bind that to something like gallium that will glow on a PET scan. And that way you can see what the expression levels of PSMA is on the prostate cancer cell. And so you get, it's sensitive for imaging to understand that extent of the disease, but it's also useful for identifying, does the patient have enough PSMA on their cell to respond to some of these PSMA-directed treatments like the radioligand treatment. And so the radioligand treatment, they use the same ligand to bind to the receptor, but they attach it to a therapeutic radioisotope. And right now it's mainly 177 lutetium, but there's some other radioisotopes coming through. And essentially what happens is this complex gets internalized into the cell and you get radiation right into the cell. And because the main cells that overexpress the PSMA are the prostate cancer cells, it oftentimes has minimal toxicity because it's such a targeted, potent treatment. So it's well tolerated. Generally, the main side effects tends to be accumulation of dry mouth because they're basically getting irradiation to their salivary glands because of the PSMA being there. There are a few other minor side effects, but it tends to be very well tolerated. But the issue is patients can become resistant to it. So about 2/3 of patients will get a good PSA response to treatment, but about 1/3 won't respond at all. And those are the ones that are already selected for having a lot of the target on their PSMA PET scan. So, if they don't have much glow and they measure that by SUV values on the PET scan, you wouldn't even consider treating them because they don't have enough of the target to warrant the treatment. But even those that have been warranted to have good target expression on their PET scan, even then about 1/3 will fail. So there's a lot of trials in progress trying to figure out combinations to kind of improve the number of people that get responses, but also to try to make those responses longer lived. And so it's a really promising treatment. We're using it a lot at St. Vincent's. We've got trials of it that we can get patients onto it, and it's well tolerated. And we are excited by it, but there are some downsides to it. And one of the big things is it's not Medicare reimbursed. So even the PET scans right now, we hear that maybe Medicare will start to reimburse the PET scans. I think there's an application in. So the PET scans might get reimbursed, but these treatments, if you go to a private practitioner, they're, about $10,000 a pop. We're trying to reduce the cost as much as we can for patients that fund it, but it's still an expensive treatment. And, I think it gets publicized a lot, and it's definitely not it's not going to cure the patient. I think, these extreme cases get flouted around the media, but we do have some exceptional responders, but that's by no means the average response that everyone's getting. So it's a treatment that I'm excited about, but it's still a work in progress and there's still some limitations with it. And there are some other treatments coming through that are targeted towards this receptor because it is so overexpressed on prostate cancer. There's some antibody drug conjugates where it attaches the receptor and it's got chemo attached to it. And there's some immunotherapy. So far, immunotherapy in prostate cancer overall has been really disappointing though. So it's being looked at in combinations rather than as monotherapy. So just some take-home messages. The treatment paradigms are really shifting a lot in advanced prostate cancer. And so men are living longer. And therefore, the GPs have such an important role in these patients and keeping them engaged with their GPs. We really, really try because we know how much you can contribute to their overall well-being. Not all the proven treatment options are readily available for men. So there's a lot of difficult discussions to have in that space. Genetic testing is recommended for all men with metastatic prostate cancer, but accessibility is an issue. And somatic testing is also important as well. But at Vinny's, we do our best. We do tend to be able to get most patients at least germline testing for free. So we're really lucky in that regard. And also the fanciest scan, so PSMA PET, just because it's more expensive and it's fancy, is not necessarily required for all patients with metastatic prostate cancer. So if they've got metastatic disease, you oftentimes don't need to do a PET scan. A CT and a bone scan, which we can oftentimes facilitate for free, is more than adequate for metastatic disease in most situations. So that's all I've got to say. So Simone's going to talk about the GP line, but if you've got any questions, comments, any patients, anything I can help with, please give me an email or, call us at the Kinghorn Cancer Center. I'm always happy to help, whether it's GU or if it's not GU and I can help you find the right person, then please let me know. Or if you have any questions after the talk today, then certainly let me know. So I think I've covered the theranostics in the chat line. As far as bisphenol A, sorry, I'm just looking at the Q&A. Bisphenol A in the etiology of prostate cancer, I'm not particularly familiar with that. I think a urologist would probably have a better feel on that. So I'm sorry, I can't answer that question. I guess BPAs, there's a lot out there on that, and those kind of studies are very difficult to get clean data from because there's so many other confounding factors. So I think the verdict is still out, but generally I think a lot of people are avoiding it for a lot of reasons, but I can't give you any exact numbers. I don't know that data exists. And then the 5-year prognosis under various scenarios for ADT and combinations. There's a really nice figure that I probably should have put in. So when they did the Peace 1 study, so that was the study of the triplet, they did kind of break it down. So ADT alone, and these are really wide numbers I'm going to give because it depends on the volume of the disease, the distribution of the disease. So someone with liver metastases is going to do much worse than someone with node-only metastases or bone-only metastases. So node-only metastases are going to kind of have the best prognosis, bone's going to come in second, and then liver's going to be the worst. And interestingly, lung metastases oftentimes kind of do similar to node metastases. So they can be a bit more indolent despite being visceral metastases. But basically with androgen deprivation therapy, you're looking at, actually I could probably come back to this. Where'd it go? Sorry. Hope I'm not making people dizzy. So in the high volume, with ADT alone, the median survival was 34 months. And in ADT alone for low volume, so less than 4 mets and no visceral metastases, was not reached. And so that's probably closer to, so it's about 3 years with ADT alone, and that's going from the moment they've got metastatic disease and need treatment to death. So that's they're still sensitive to ADT because they might be sensitive to ADT on an average of 18 months alone. So, but then once they get castrate resistant, the amount of time they respond to treatments gets less and less. So it's about close to 3 years for low volume disease. This is survival. And then for low volume disease, it's probably closer to kind of 4 to 5 years that these patients will be, most will be alive at 4 to 5 years. Once you start to add docetaxel, you get to kind of like a 3 to 5 year average median survival with docetaxel. And the 3 years is more for the high volume and the 5 years is more for the low volume. And then with the abiraterone and the enzalutamide and that, it's probably relatively similar. So you're looking at kind of that 3 to 5 year range for those drugs plus ADT. And then with the triplet therapy, the survival is not mature for the low volume, but we were looking at about 5 years for the high volume patients. So with the chemotherapy and ADT, we're looking 3 to 5 years. And for those high volume patients, kind of 3 to 3.5. For the high volume patients with the ADT plus the tablets, the androgen signaling, you're looking at like 3.5. And then with the triplet, you're getting close to 5 years for the high volume. And a lot of patients will have high volume. They'll just have more than 4 bone metastases, or they'll have something in the liver. And then when you get to the low volume, we're looking at, hopefully 5 years and beyond. And so and they're on androgen deprivation therapy for all that time. So that's why their bone health, their mental health, their sexual health, and their cardiovascular health is so important. So I think that's all I had to talk about. And I don't see any other questions in the chat line. So unless anyone wanted to ask anything verbally, I'll hand it over to Simone. Okay, thanks. I'll stop sharing. But yeah.
Thanks, Megan. That was great. Really comprehensive and thorough. Our next speaker, we're just going to have a little short presentation from Simone Ray, who is the Cancer Clinical Nurse Consultant at St. Vincent's and the Kinghorn Centre, and she manages the new GP Cancer Support Line. She'll be discussing the GP Can Share service and the GP Cancer Support Line. Thank you, Simone.
Yes, thank you, Rebecca, and thank you, Megan. Good evening, everyone. Thank you for the opportunity to briefly introduce the GP Can Share program to you all. My name is Simone Ray, and I have the pleasure of running the new GP Cancer Support Line for the GP Can Share service. This is in my capacity as a specialist cancer nurse consultant. The initiative is a collaboration between the Central Eastern Sydney Primary Health Network, South Eastern Sydney Local Health Network, the Sydney Local Health District, and the St Vincent's Health Network campus. And we have a focus on enhancing cancer management in primary care, improving communication channels between the primary and acute care settings to have enhanced information sharing. We have clinical nurse consultants based in cancer centres and hospitals across the region, supporting general practice teams. GPs and practice nurses now have a link to facilitate a more in-depth shared care model via our GP Can Share team nurses. These include my colleagues Mary Hayes and Susan Stapleton, and they're cancer nurses who are based at St Vincent's campus and the Kinghorn Cancer Centre. They cover all cancer types and streams, and they're an immediate direct link to the timely information and cancer information that you need as a human resource and a practical resource. The other component to the program is our centralised GP Cancer Support Line, and this has been established to cover cancer services within the collaborating health districts across the region, as mentioned beforehand. When you call our contact number, which is 1800 GP line, we aim to provide the timely specialist advice and information you seek on a range of topics as displayed currently on the screen. A common theme of calls I've found to date, for instance, is that GPs have valued having access to some more thorough information and details on admissions, discharges, and current treatment plans. For instance, they've valued reported valuing discussing specific treatment decisions that might regard medications and contraindications, and also referral options. Of course, they would like to tailor their care to their to promote patient-centred safe options, and this could be possible with some extra support from cancer specialists. And so thankfully it's not just me. The cancer support, specialist support will be from our specialist consultant colleagues, allied health cancer specialists and nurse specialists. We all want to provide that extra support and advice you need in primary care. The program hopes to improve the healthcare experience and outcomes for patients and their GPs across the Central Eastern Sydney Primary Health region. Our cancer service and support line is available Monday to Friday, 8 a.m. to 6 p.m, including public holidays, and we'd love to hear from you on 1800 GP line. Thanks very much, everyone.
That's great. Thanks, Simone. Very useful service for GPs and also mentioned practice nurses. Our final presentation tonight is by Dr. Orly Levy, who is a consultant haematologist at St Vincent's Hospital, Sydney, and the Kinghorn Cancer Centre. She'll be providing an update tonight on COVID-19 vaccine-induced thrombocytopenia.
My name's Orly Levy. I'm a haematologist at St Vincent's. I'm a clinical haematologist and a laboratory haematologist, so I work between the Kinghorn Cancer Centre and SIDPATH. And I'm also part of the GP Can Share project from a haematology perspective. This talk is not a cancer talk. I was going to give an overview of myeloma treatments, but given that we have an emerging and new topic in haematology, which I think is of great interest to everybody at the moment, I thought it was opportune to swap that for this talk on vaccine-induced thrombosis and thrombocytopenia, just to give a general overview and some figures to date of the Australian experience, which really has been an enormous learning curve over the last few months. So my talk is a shortish talk, but obviously questions welcome throughout, and I can answer anything at the end. So just in terms of the terminology of what we're talking about, there have been a few different terms used interchangeably throughout the time that we've been aware of this phenomenon. And the working term at the moment, and the one that's used most commonly, as defined by the Thrombosis and Haemostasis Society of Australia and New Zealand, is VITT, or vaccine-induced immune thrombotic thrombocytopenia. The TGA will refer to it in its publication as TTS, which is thrombosis and thrombocytopenia syndrome. These terms are interchangeable in terms of what we're talking about. Earlier in the piece, it was referred as VIPIT, vaccine-induced prothrombotic immune thrombocytopenia, and VAT, vaccine-associated thrombosis and thrombocytopenia. But for all intents and purposes, we're talking about the same phenomenon. So the history of VITT has obviously been a short history, and in late February of this year, it was observed that in very small numbers of people who had received the AstraZeneca adenoviral vector-based vaccine, there was a prothrombotic syndrome observed. And very shortly thereafter, there were very similar findings observed in a small number of people who also received another adenovirus-based vaccine made by Johnson & Johnson. Initial reports were published in April, and it looks like my slide there has actually cut out the screenshot of the New England Journal of Medicine release, which published the phenomenon for the first time after these individuals were presenting with thrombosis and thrombocytopenia and requiring often intensive care management. Sorry, there's the brief report that was published. Just going through that. So what we know about this disease is that it's caused by the production of antibodies that recognize platelet factor 4 or platelet factor 4 polyanion complexes, which are surface receptors on platelets which assist with platelet activation and clotting. We know that these antibodies develop after vaccination against COVID-19 with the adenovirus-based vaccines, which of course are using adenovirus as a Trojan horse with a snippet cut out and a bit of the COVID-19 genome inserted to produce a spike protein or an immune response and therefore immunity to COVID-19. So these antibodies have the potential to activate platelets via the FC2A receptors, and these are the receptors that bind the tail portion of IgG, or the FC portion that interacts with the cell surface. This platelet activation leads to marked stimulation of the coagulation cascade and clinically significant thromboembolic complications. And as you probably well know, it's most similar to heparin-induced thrombosis and thrombocytopenia. It's similar in its presentation and its pathophysiology. However, the traditional testing that we use for HIT, those assays don't detect the VITT platelet factor 4 antibodies, and the antibodies are not heparin dependent. They're dependent on the vaccination side effect. So what sort of thrombosis do we see in VITT? So we can see sort of garden variety DVT and PE, and the thing that makes VITT quite characteristic is that those thromboses can also occur in unusual sites. And by that I mean the splanchnic vessels, be that splenic, portal or mesenteric veins, also adrenal veins, and therefore these patients can present with adrenal failure, and the cerebral and ophthalmic veins, particularly cerebral venous thrombosis. Patients can have concurrent arterial thrombosis, and if patients have arterial thrombosis, they generally will also have venous thrombosis. So it would be very unusual to have isolated arterial thrombosis in these patients. and they can present with ischemic stroke, often in the middle cerebral artery. We don't really understand why it is that these patients get these unusual thromboses, but they tend to have a similar distribution to other thrombophilias in haematology, which present with unusual thromboses, such as the myeloproliferative disease with the JAK2 mutation, as well as paroxysmal nocturnal hemoglobinuria. So we know that the two most commonly used adenoviral vector-based vaccines have been implicated in VITT, and that's the AstraZeneca vaccine produced through the scientists at the University of Oxford and the Serum Institute of India, as well as the Johnson & Johnson vaccine, which have a similar mechanism of action, but obviously not as commonly used in Australia. There are other adenoviral vaccines which are being used worldwide, and some of these vaccines have not had reported VITT, and it's unclear at this stage whether that's due to a biological difference in the vaccine themselves or reporting difference. So, for example, the Sputnik vaccine, and whether or not the same phenomena is happening, but because of the reporting in the countries that it's being used, or the presentation of these patients, we might not be picking it up. There have been no definite cases of VITT following the mRNA-based vaccines. There was one possible case, so not actually categorically proven, with the Moderna vaccine. So here's another sort of landmark NEJM article at the inception of what we started to know about VITT, published by a group in the UK, based on a lot of UK data as well as data from Israel, where patients were being vaccinated very rapidly at the beginning of this, the beginning of the availability of the vaccination program. And these were the major findings of that paper, which was published. And of the 294 patients with suspected VITT, 170 of those were proven as definite, and 50 of those patients were probable. And you can see there in the table that the distribution of age, mostly middle-aged patients in this study, most commonly presenting between 10 and 25 days post-vaccination, with very low platelet counts. And you can see there that the most common site of disease in terms of thrombosis was in the cerebral veins. D-dimer levels in these patients tended to be markedly elevated, so greater than 5 times the upper limit of normal. Sorry, this is fancier than I actually anticipated. And in terms of the major outcomes for the patients, they're summarised in this table. But just by way of summary, there were no individual risk factors that they could identify for VITT, and there was increased mortality among patients who presented with severe thrombocytopenia, as well as the patients who presented with, cerebral venous sinus thrombosis and intracranial hemorrhage, and patients who had markers of severe coagulation activation. VITT primarily affected patients less than 60 years of age, and it was common for patients to have multiple sites of thromboses as well as arterial events, as I mentioned earlier. The overall mortality of patients was around 22%, which is quite high. I think this is because these were early figures, and we didn't really have an idea of how to manage these patients and how to detect these patients earlier in the Delta wave of the pandemic. And this was related to their baseline platelet count, and intracranial hemorrhage was independently associated with death. If the platelet count was less than 30 with intracranial hemorrhage, the mortality was in the range of around 73%. So now I just want to summarise the Australian experience to date. And the most useful information I find comes from the TGA, who weekly will publish a safety report, which is up-to-date information. And so the data that I've included in these slides comes from the weekly safety report, which was published on the 14th of October. And this gives data current to the 10th of October. And at that point, we'd administered, or you'd administered, 31 million vaccine doses in Australia. 18 million of those were first doses and 13 million were second doses. And the total Australian reports that were assessed as TTS or VITT following the AstraZeneca vaccine at that point were 152 cases, of which 85 were confirmed and 67 were probable. And that's from approximately 12.5 million AstraZeneca vaccine doses. And this is just a breakdown of the age bracket and the estimated rate per 100,000 AstraZeneca vaccinations in each age bracket there. So the TGA have concluded that of those reports, 9 reports of death were linked to immunisation from the 597 reports received and reviewed. And that's overwhelmingly in those who are greater than 65. So as you can imagine, when a mass vaccination program is rolled out, there'll be a number of coincidental or unrelated deaths that are reported that need to be investigated. And 9 of those have been found to be linked to immunisation. These deaths occurred after the first dose of AstraZeneca. 8 were related to VITT or TTS, and 1 was a case of severe ITP leading to a death. The cases occurred most commonly between 2 and 3 weeks post that first vaccination. And in Australia, no cases have definitively been linked to a second dose of AstraZeneca vaccine, which I think is useful information and useful information to pass on to patients. The severe cases appear to be more common in women in the younger age groups, which is a worrying finding. And nearly half of those cases required treatment in intensive care. So of those 8 deaths that were related to VITT, 6 of those were in women. And in Australia, the risk of dying of TTS post-vaccination is approximately 1 in a million, and 1 in a million people receiving the first dose, and probably somewhat less when both doses are taken into consideration. So this is a table which shows the total confirmed and probable TTS cases to date. And the classification system used there is the US CDC classification. So the tier 1 cases are people who have had clots in an unusual location, as I described earlier, as well as a low platelet count, with or without detectable antibodies against anti-platelet factor 4. And those who are a tier 2 were clots found in common locations, as well as a low platelet count and anti-platelet factor 4 antibodies. And then there are a number who were not classified because they didn't quite meet the criteria for tier 1 or tier 2. So of all ages, totaling 112, fairly equal for men and women. And the 50 to 59 age group there having the most tier 1 cases. So now I just want to turn to acknowledge this remarkable group of people, colleagues from across Australia who, when we started to learn that, that vaccine-induced thrombosis and thrombocytopenia was a major emerging health interest given the vaccination rollout, this group of people who have an interest in thrombosis and clotting were convened. Vivian Chen, who is a haematologist at Concord Hospital, is the chairperson for this group who are from the Thrombosis and Hemostasis Society of Australia and New Zealand. And they're a working group who have come together to create guidelines and referral pathways, validate assays, and give feedback to the medical community about this interesting problem. So they first met the Easter weekend of April of this year. And as I said, they coordinate all the diagnostic testing for suspected VITT for the whole of Australia. So each state is able to perform the platelet factor 4 antibody test, which is an ELISA test. It's a screening test. And it's similar to the HIT antibody test, but as I mentioned, it's got subtle differences because the HIT test actually will not detect this particular platelet factor 4 antibody. So that can be performed in each state. But what that does is it detects the presence of the antibody. And as with a lot of these antibody tests, it can be used to guide management, but it's not confirmatory in that you can have an antibody present, but it doesn't necessarily suggest that it is an active antibody that is causing the disease phenomena that you have in the patient in front of you. So that needs to be confirmed by functional testing or similar to serotonin release assay testing. And that's all done in Sydney. So all of those positive cases come to a centre in Sydney to have confirmatory testing. All of the suspected cases that have been referred to this working party group are reviewed by the group, and there are fortnightly meetings at the moment. Initially, this group was meeting weekly, so you can imagine the volumes of information that needed to be processed there. And the group's responsible for developing and updating diagnostic treatment algorithms, as well as consensus guidance, because a lot of the time this is consensus and expert opinion rather than evidence, because it's emerging literature, as well as working with other specialist societies, and it's a multidisciplinary group. And this is the paper that was released in the Medical Journal of Australia, which outlines the approach that has been recommended in Australia for the diagnosis and management of VITT. So I just want to draw your attention to this website. It's the THANZ portal, which is, I find, a really useful resource. And it's a constantly updated resource that anyone can access. So it's not a password protected portal. It can be used by anybody to access up-to-date information and lots of useful links. There are documents that can be edited within the portal. And it gives a good brief on suspected adverse events following immunisation and what notifiable conditions are reportable to the TGA, how to go about that, and a traceable process for that. So now just a bit of practical stuff about VITT in terms of pathways, diagnosis and management, and how we're doing things at the moment. So the pathways have been published in sort of both haematology societies as well as emergency medicine societies. And to enter the pathway, obviously, you need to have symptoms suggestive of either thrombosis or thrombocytopenia. Patients are considered at risk of VITT with these conditions if they are within 4 to 42 days of an AstraZeneca vaccine or an adenoviral vaccine. If they've got thrombocytopenia or a falling platelet count, so they don't necessarily have to be below the reference range, but there has to be a decline in their platelet count with a D-dimer of greater than 5 times the upper limit of normal. Now, this is obviously sensitive, but it's not specific, but it adds weight to the probability of the diagnosis. Some patients have a reduced fibrinogen level, but it is very variable, and we've certainly seen patients who don't have a marked reduction in their fibrinogen. The investigations that would be performed going forward would be based on the severity of the presenting symptoms. So obviously people who you suspect have a cerebral venous sinus thrombosis can present with headache, visual change, seizure, focal neurological deficit, and symptoms of encephalopathy. And obviously they need quite urgent venous cerebral imaging, usually with MRI. Sorry about my daughter sitting next to me. People who present with splanchnic vein thrombosis can have more subtle symptoms, and this can include abdominal pain and nausea. And obviously everybody's familiar with the symptoms of patients who present with the more common sites of thrombosis, such as DVT and PE and arterial thrombosis. There have occasionally been reports of rare right ventricular thrombosis or aortic mural thrombosis, which are obviously very difficult to diagnose. But in VITT, in terms of reducing mortality, the early diagnosis of these thrombosis and starting treatment early is the key to improved outcomes. So this is the THANZ algorithm. As I said, the Emergency Medicine College has a very similar one, but I'll just talk you through this. Basically, it's what I outlined earlier with the points, but if you've got persistent organ-specific symptoms suggestive of thrombosis 4 to 42 days post-vaccination, and a platelet count of less than 150, D-dimer of at least 5 times the upper limit of normal plus or minus low fibrinogen, then you have your imaging of sites appropriate to symptoms, and you would collect 4 serum and 4 citrate tubes for VITT testing. The form for the VITT testing can be downloaded in the THANZ website. I suspect that by the time this stage of investigation is occurring, it's happening in the emergency department or in the hospital, but that's where it is, just for your knowledge. If thrombosis is confirmed, there's the sample request form, my apologies. If thrombosis is confirmed, then obviously patients need anticoagulation. But importantly, the anticoagulation needs to be with a non-heparin anticoagulant. And this can be with a DOAC or bivalirudin or similar. And depending on the severity of the presentation, we would usually recommend intravenous immunoglobulin 1 to 2 grams per kilo in 2 doses. Platelet transfusion is not recommended in these patients because it tends to fuel the fire, as it were, and further stimulate the prothrombotic state and coagulation pathway. These patients will have an ELISA test, as I mentioned earlier, to screen for the presence of the antiplatelet factor 4 antibody, as well as functional VITT testing, which are generally sent off in tandem. And they both do take some time to come back. So based on your degree of suspicion and how many boxes are ticked in terms of the presentation, you would institute treatment presumptively or empirically, because there wouldn't be time to wait for the turnaround of those tests. If both of those assays come back negative, then that makes the diagnosis of VITT, that makes it a negative diagnosis of VITT, or very unlikely diagnosis, and you can review the choice of your ongoing anticoagulation in consultation with a haematologist. If either of them are positive, then the safest path would be to continue the non-heparin anticoagulant. And we've tended to be quite conservative in our approach to this. It would usually be safer just to continue the current anticoagulant rather than switch to a heparin anticoagulant, unless there was a very good reason to do so and you were quite convinced that this wasn't VITT. If there's no thrombosis, then you could consider prophylactic dose anticoagulation with a non-heparin once again. You'd send off the same testing, and if those tests are positive, at that stage, you would consider therapeutic anticoagulation and functional VITT testing. If that's positive, you continue with your non-heparin. If it's negative, you can review again and discuss with a haematologist. This is the alternative algorithm. It has the same information. It's set out a little differently. I think it's probably a little more user-friendly than the haematology one. And this is just a slide about the confirmatory testing that I alluded to earlier. So the screening testing is the ELISA, and the functional testing is demonstrating the ability for the serum or plasma to activate the platelets in vitro. So platelet activating antibodies are considered pathological and requisite for the confirming the diagnosis of VITT. And it's best to send them through hospital-based laboratories. There is some availability through the private laboratories, but the problem with doing platelet-based testing, particularly in the functional setting, is that if the sample is collected and left to sit, or collected and left at the wrong temperature, you can have a lot of issues with false positive results, because the platelets will already be activated by the time they get to the assay. It's important that this test is collected prior to intravenous immunoglobulin or anticoagulation, because it can cause false negatives. And the intravenous immunoglobulin can actually suppress the in vitro platelet activation. So you can take another sample 5 days after IVIG if the first sample inadvertently has been collected post IVIG. So how do we treat suspected VITT? So as I said, most need treatment quickly, and most need specialist consultation with haematology if that's the case. We recommend non-heparin anticoagulant. It would be a very similar treatment approach to a patient that had a heparin-induced thrombocytopenia. Intravenous immunoglobulin is reserved for patients with severe thrombosis, or those who don't respond quickly or at high risk for deterioration. So those are patients with very low platelet counts, very low fibrinogen. Occasionally in extremely unwell patients, we will add high-dose methylprednisone or commence plasma exchange, and that's often in patients who have a cerebral venous sinus thrombosis. In patients who develop progressive thrombosis or new thrombosis whilst they're anticoagulated or post-IVIG, these patients generally do need plasma exchange for some days in order to stabilise them. The choice of anticoagulant is probably guided by familiarity and availability. Bivalirudin, dinaparoid we use quite commonly, and rivaroxaban and apixaban are very easy to use, so they are also used very commonly in patients who are more stable. We tend not to use warfarin, but in theory it can be used. And the anticoagulation is not lifelong anticoagulation, so it would be guided by the clinical presentation as you would with any other patient, and generally speaking, it's between 3 and 6 months. It's safest for these patients to be in hospital until they can demonstrate that prothrombotic state has been quelled, and that you're not getting quite so much thrombin generation, and that is signified by an increasing platelet count, a falling D-dimer, and a normal fibrinogen level. You can check for resolution of antibodies with the ELISA prior to the cessation of their anticoagulation, but generally it's more of a clinical decision. That's all very well and good when somebody is a definite VITT, and to be honest, it makes it very easier when it's definite, but there's probably more patients who fall into the grey zone of possible VITT. So they're suspected without thrombosis in a lot of cases that have presented, and these patients need to be monitored very closely, basically with repeat blood tests, full blood count, D-dimer and fibrinogen, and this can be done every 3 days. You can consider using anticoagulation with a non-heparin if that D-dimer is extremely high and they've got a positive ELISA. And the current recommendation is consideration of fondaparinux or an oral DOAC at prophylactic dosing. You should still avoid platelet transfusion, and some of these patients need to be hospitalised, but not invariably. IVIG can be considered if you've got signs to suggest progression despite anticoagulation, but we don't yet have data to advocate for the prophylactic administration of IVIG. And as you can imagine, the demand for IVIG is enormous at the moment. So I just don't think we also have the resource capability to be able to make that recommendation at the moment. The anticoagulation should be time limited again until the HIT, ELISA and functional testing is negative. I guess as an addendum, we're talking about VITT here, but ITP should also be considered in patients who present with thrombocytopenia with a normal D-dimer and fibrinogen, and it can be quite catastrophic. As I said, one of those deaths associated post-vaccination was an ITP patient, and it is being seen occasionally post-vaccination. In patients who present with a cerebral venous sinus thrombosis with an intracranial hemorrhage and platelets of less than 30, we would strongly consider immediate plasma exchange, and that's with 1.5 total plasma volumes using FFP as the exchange product or as per local process. The IVIG is generally given after plasma exchange in this instance, and anticoagulation can be given with short-acting parenteral agents as soon as is practical. So the ATAGI advice on the AstraZeneca vaccine, you're probably very familiar with this already, but I'll just go through it again. So there are several medical conditions that have been identified as having potential similar mechanism of action to VITT. And I guess that's important because we don't have good data to say that having these conditions actually increases your risk or makes it worse if you get VITT. But for safety, we know that people who have had these conditions should not receive an adenoviral based vaccine. And they're a limited cohort of patients. So anybody that has a history of cerebral venous sinus thrombosis, heparin-induced thrombocytopenia, splanchnic vein thrombosis, or the antiphospholipid syndrome with thrombosis and or miscarriage, are recommended to receive the Pfizer vaccine over AstraZeneca. People who just have antiphospholipid antibodies but don't have any clinical manifestations of those antibodies don't actually fit the criteria for having antiphospholipid antibody syndrome, and therefore they can actually have the AstraZeneca vaccine, though I suspect there'd be a lot of hesitancy in a lot of these patients, but there's nothing to suggest that they would have any precedent for the prothrombotic phenomena that occurs. So that's actually all I had to say. I just want to acknowledge Dr. Joanne Joseph, who I work with at St Vincent's, and Dr. Vivian Chen for some of the data that I've presented tonight. My screen, I have to adjust so that I can actually see the questions, but I'm happy to take any verbal questions because I can't actually see the ones that have come through on the chat.
Oh, I can read that out for you.
Thank you.
Yeah, it's one question from Philip. Would intravenous administration of the vaccine possibly be implicated in the etiology? It is not advised that when giving a vaccine, there is no need to aspirate to ensure that you're not in a vein, although I always do. Studies in mice show that IV administration of mRNA vaccines is associated with myocarditis.
I think the mechanism of action is very specifically immune mediated. So I'm not sure that specifically for the adenoviral vaccines, whether an intravenous route of administration would actually increase the rate of that, because it's more of an immune response rather than a direct toxicity, which I guess you might speculate is involved with the mRNA vaccine complication, but I'm not aware, so I would have to go and double check that.
Okay, thank you. Are there any other questions from either of the presentations? Okay, great. Well, thank you to the presenters, and thank you so much for everyone that attended tonight. It was really interesting and hearing on what's going on in both the prostate cancer and the COVID vaccine world. Just a reminder for all attendees, if you can take the time to complete the survey, evaluation survey that will be sent to you just after this in the slides or in an email tomorrow. There is an option in the survey to indicate if you would like some promotional materials sent to your practice in regards to the GP Share service and the GP cancer support line. There's a handy monitor sticker with the phone line, so the number's easily accessible. There's also some information on both the service and the phone line on the cancer management page of the CESPN website if you require any further information or are interested in either service. Once again, thanks for everyone's attendance and interest tonight, and we'll look forward to seeing you soon. Bye.